let's say endometrial, or ovarian tumors or infertility or whatever. Instead of that, because that's something theory, you may make a presentation, someone who is preparing that presentation reads about that, how much they retain, that's a different matter. But what I would expect when we have case presentations, then we are discussing a particular situation in one set of circumstances. That's number one. Number two, along with that, we can include a small overview of that particular subject. Thirdly, and that case should be decided a week earlier, which means if next Wednesday some case should be presented, that will be decided today. And the person who is going to prepare it and the subject or the topic will be obviously disseminated to the participants, or all of them, or and also on WhatsApp group, so that those who join us, they also have the opportunity of going through that. So you prepare that topic, everyone, you read it up from the books, one book, two books, net, etc. And then we have discussion, say there'll be 15 minutes presentation, 15 minutes question answer, and the rest of half an hour will be discussion over that, the various aspects, right? So Anika है, yes, आप एक बना लो, एक वो उसका बनाने का नहीं है. Sure, if you want to participate in discussion, we will very much welcome you. You can do that. आपने शाम को not necessarily you, अगर आप नहीं हो तो आप मेरे क्लिनिक पे आ जाना, मैं आपको एक हिस्ट्री दे दूँगा. इसी तरह से जो केस लेट्स से वो जो सिजेरियन के लिए है, जो हिस्टेरेक्टमी के लिए है, जो मायोमेक्टमी के लिए है, जो लैप सर्जरी के लिए है, आप उनकी हिस्ट्री लेके उसको भी प्रेजेंट कर सकते हो. वो हमारे में से होगा ना, मेरे रुबीना के या डॉक्टर सोहेल के क्लिनिक्स में से होगा, तो आप लेके उसको उस तरीके से भी आप प्रिपेयर कर सकते हो. बट वो शाम को आ जाना, तो मैं वो तुम आ जाना या किसी को बता देना, तो वो केस हिस्ट्री उस तरह से मैं दे दूंगा. Good, Dr. Yasmin, we welcome you in case presentation and discussion. So, agar if you would unmarried with myoma today, yes, sure. ये आप present कर देना, हम भी आपको present कर देंगे ऐसी चीज. यही ले लेना, मेरे से भी ले लेना एक केस. परसों तरसों एक लड़की आई थी, unmarried लड़की इस तरह से. Now, today we wanted to complete this anterior abdominal wall and the MCN. The purpose of last time discussing anatomy of the anterior abdominal wall was that you would know what are the structures and how are they configured and how you go through that. But at the same time, it is also important that while you are assisting or you are partly operating or doing a procedure, you should be doing it in a proper way. You should be holding the instrument in a proper way as it is supposed to be. Although now I see that the emphasis on these kinds of instruments, etc., is now kind of dwindling. When I started my training at that time, when we looked at the operative gynecological books, there were instruments which were named after people who either invented or introduced them and then brought about certain modifications within them. So in a scissor, they would make a bend and they would call that, or there would be a clamp or a myomectomy clamp or Boney's myomectomy clamp, for example, or some forceps named after someone, Wrigley's forceps or Keeland's forceps, like that. Now we call outlet forceps. Now, you don't even know Wrigley's forceps. How many of you had heard about that? The word? Not really. Wrigley's forceps was the outlet forceps. And if I ask you what is the spelling of Wrigley's, maybe half of you. Huh? WR. WR. तो वो उस तरीके से शुरू होता है. ठीक है जी. अच्छा, अब when we are talking of opening and closing the abdomen, we also need to take into account what are the materials that we use. For example, the suture material. What are different types of sutures? So मैंने आज hastily haphazard सी है, मेरे पास time कम था, लेकिन मैंने वो एक छोटा सा किया है, 7-8 स्लाइड्स हैं। वी लुक एट दोस कि क्या क्या है सूचर्स। ये हाँ जी, आपने मुझे भेज दिया था वो।
जी जी, व्हाट्सएप कर दिए।
व्हाट्स ओके, ये लिंक है या
आपकी मर्जी, आप दोनों तरीके से आप ज्वाइन कर सकते
ये जो जूम मीटिंग का लिंक है इसको मैं उसमें डाल दूं, कॉपी
हैं। वेब
करके।
यूआरएल में डाल।
और आ गया। All right, those who have joined us on net, can you name various types of suture material that we use?
So, sir, may I?
Ji, please go ahead.
Ji. So, the suture materials are basically divided into two major groups, like absorbable and non-absorbable. In non-absorbable, we have silk and proline, and in absorbable, we have vicryl.
आईडी वाला जो है वो मुख्तलिफ नंबर है ना, 826। एब्जॉर्बेबल, नॉन एब्जॉर्बेबल आपने कहा,
जी।
और
फिर अब नॉन अब्जॉर्बेबल में बताया कि सिल्क होता है एंड प्रोलीन होता है, और सिल्क एंड प्रोलीन एंड अब्जॉर्बेबल में आ जाए तो फिर वाइक्रिल के डिफरेंट नंबर्स हैं, कैटगट है।
ओके,
Recording in progress.
ये स्क्रीन शेयर को अलाउ करेंगे
सर
जरा।
मैं भी रहा।
हो गया,
हो जाता है सर।
मेरे पास नहीं है।
जी, डॉक्टर साहब को कोर्स बना।
ये इमरान से कहते हैं कि कर दिया करें इसको,
वो सर जब आप ज्वाइन करते हैं ना तब हमें
उसके बाद से कर दें। ओके,
कर दिए।
ठीक है। अच्छा, ऐसा है कि different types of sutures हैं, and there are three main categories by which we classify them. One is absorbable and non-absorbable. Second, you can classify them synthetic and natural fibers, and monofilament and multifilament. अब from you absorbable का कोई नाम लोगे कोई?
Vicryl, catgut.
Now, catgut is what kind of absorbable suture? It is natural.
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 And vicryl is monofilament or multifilament?
It's
Vicryl is
Monofilament.
vicryl is multifilament. Braided suture है जिसको कि वो किया गया 2 या 3 उसकी लेके और उनको आप इंटरट्वाइन कर दें, और catgut is a monofilament. So therefore फिर उनकी अपनी जो होंगी प्रॉपर्टीज और खसूसियात होंगी. Now absorbable sutures can be natural and they can be synthetic. आपने दो नाम लिए पहले, एक नेचुरल कैटगट है और सिंथेटिक में आपने वाइक्रिल का नाम लिया. ये दोनों ही absorbable suture है, vicryl भी absorbable है, लेकिन vicryl synthetic है, और जो natural suture है वो आमतौर पे catgut, it's got nothing to do with the cats. It is derived from the muscular coat of the intestine of sheep or cattle like cows, etc., buffaloes, etc. From bovine are related to cattle. And this is treated with aldehyde to give it some strength. And that's called plain catgut. You don't use plain catgut here too much, but plain catgut gets absorbed earlier. Within a week or so, it's tensile strength that starts to dwindle. And then it is, if treated with chromium trioxide to further strengthen and then delay its absorption, that becomes chromic catgut. So chromic catgut is usually dark brown, and plain catgut is of pale color, light color. And it is many times, or I sometimes use it in those sutures where you need to have separate approximation of the thick subcutaneous layer, fat. So you approximate it with that, where it is not possible to take that much of tissue along with that subcutaneous stitches that we apply, usually with Proline. So in those interrupted stitches with plain catgut are sometimes applied to have that approximation, and which would last for say about a week to 2 weeks. By that time, healing would have taken place and the tissues would be. So you do not leave any dead space below the skin stitches. Natural absorbable sutures can get degrade now. Then the properties, how they degrade by proteolysis, and synthetic sutures degrade by hydrolysis. Those sutures which degrade by proteolysis, they would evoke a local reaction, some inflammatory reaction, and that inflammatory reaction in response to the breakdown of those proteins that may cause a little bit of induration or pain, or which is more compared to those which degrade by hydrolysis, because in those cases the local reaction is minimal. There is inevitably some local reaction, inflammatory reaction, but that is minimal and much less compared to the effect of the natural fibers. So that is the advantage of natural and the. Next, we come to non-absorbable sutures. These are obviously applied where you would want the strength to remain. For example, you would be aware that we use Proline for closure of rectus sheath in midline incisions, because those aponeurosis they have, and in a longer incision and even a subumbilical incision, vertical incision, Proline, which is a synthetic monofilament non-absorbable suture. Proline, and you use we'll come to the strength of the individual fibers later, but it is used so that it keeps the aponeurosis or the rectus sheath well strengthened. Otherwise, there would be a likelihood of formation of incisional hernia in the midline that is more prone, that is like. So therefore, it is used in where extra strength for longer period of time is required, and it is going to be buried under the skin or subcutaneous tissue, where it will not be in the superficial part, so that it will not be palpable, or it will not give rise to irritation or a feeling of something pricking in that area. So therefore, it is buried well in under the subcutaneous tissue or ligating tube. And general surgeons also use it for the second layer of bowel anastomosis. There are different kinds of sutures there. Now, because synthetic sutures are also such which last quite long, and then they absorbable synthetic sutures like PDS, they take longer, and therefore general surgeons would be using those in bowel anastomosis. And hernias repair is also carried out by non-absorbable sutures deep down there. And of course, we utilize that in skin. The proline is used for subcuticular or even interrupted stitches of. There are advantages of those monofilament, non-reactive, or those materials which will not evoke an inflammatory reaction. So monofilament, if you look at monofilament and multifilament, so monofilament is just one filament. It is a single, it is not braided, it's single thing. And the advantages are that a disadvantage actually, that is higher memory, which demands more handling. Memory is that property of the suture to get back to its original shape. I mean, in whatever shape it is handed over to you, you apply that. And if you just lose it, just try it on protein. If you just give one knot and leave it, it tends to loosen. And it kind of unravels, unfolds, right? So it gets back to its original position. That is known as memory of the suture material. On the other hand, if you give one knot of catgut or even vicryl, catgut will not budge at all, but vicryl will be to some extent because of the multi-filament. So monofilament have this tendency of loosening up, and therefore they require more knots to strengthen and to keep that security. But the advantages are that monofilament would pass through tissues more easily. It will cause less damage as it goes along its path, whereas multifilament would be more abrasive because of its irregular surface. And its fractures less than multifilament. It breaks down less than its strength is good, and causes less inflammatory reaction than their multifilament sutures, because it is just monofilament, so there isn't anything to get in between. When you look at braided thing, then braided sutures have, or multifilament sutures, they provide that greater surface area and some areas in between the. Now, if you look at braided, ये जो hair की braid आप कर लेते हो, तो उसमें जब आप देखते हो, there are areas in between those various components of the braid, and therefore multifilaments would have that property as well. Multifilaments are more pliable. They are softer to use and hold knots more securely. They have less memory, so they do not go back to their original state, and easier to handle by the surgeon, but cause more friction through tissues, have increased capillary and surface area, and increased tendency to inflammation and infection. Now, with advancements, technological advancements, they are now being coated to make them slide through tissues more easily, so they become more smooth and have properties similar to monofilament sutures, and can also be coated with antibiotics to make them more infection resistant. But of course, all these extra treatments of the sutures, they make them more expensive than the ones that we are more used to using. Tensile strength is also something which we need to look at, and this is the property of the suture to keep itself intact, and the breaking point. You must have seen that if we are using a vicryl and then you start using a thinner catgut suture, and if you apply the same kind of, it will break. So that is the difference between the tensile strengths of different sutures. And it is obviously, if it is thicker, it will have greater tensile strength and will break more with greater force. So sutures are numbered by their size relative to their diameters. The finer one would have lesser number to denote it. For example, number 1 is, or number 0 is thinner. Number 1 would be thicker. Number 2 would be even thicker, and so on and so forth. So they go up to number 10. But we use only up to number 2 sometimes. And since we previously, when vicryl was not so conveniently available, we used catgut for hysterectomies. And we use number 2 for ligature of the pedicles, number 2 catgut. But now we don't use that, we use Vicryl because it's got greater tensile strength. It is a synthetic absorbable suture, it lasts longer, and with lesser thickness, that is just number 1, would do better, would provide greater strength, would cause less inflammation, and healing would be facilitated by that. Therefore, number 1 Vicryl would be better than number 2 catgut. So thin sutures are those that have the greatest diameter, numbers of zeros. So 1 0 is thicker, 2 0 is thinner, 3 0 is even thinner. And you know that we have that catgut also in proline, also in Vicryl. So we use Vicryl 1, Vicryl 2 0, etc. So this is how we describe the, or we ask for that, or we choose that particular suture material. Then comes the needle. You also need to be aware of that. What type of needles are there?
Straight needles, round, I think.
Yes. What is the difference between a round bodied and a cutting needle? Round bodied is less traumatic.
Doctor, sir, round bodied is used where in the soft tissue like muscles and peritoneum, but the taper cutting include used in the skin or in the rectus sheath where cutting
Right.
is needed.
Right. And nowadays, you see, when previously the needles used to come separately, and they used to have an eye, as we know in a sewing needle. If you look at sewing needle, there is an eye, and similarly in a surgical needle also there is an eye. And mostly, for example, when we use silk, particularly at the time of cerclage, then you see that that needle has an eye through which the thread is passed or silk is passed, and then the rest of that is the body, and then there is a point. The point can be rounded, which is less traumatic, and there is a sharp point when you have to pass the needle through thicker tissue, and therefore when I use curved cutting or pointed cutting, we call that cutting needle, not round body, cutting needle, which is tapered and which is pointed, and which is also an eye. So that's an example of round body. So eye is where the sutures attack, or when we have these newer materials, even catgut and others, they now come already the suture material is attached with the needle, and it's inserted in that. You don't have to thread it into the needle eye, and but that area still is called the eye. And the body is the most substantial part of the needle and connects to the eye and the point on the other side to determine the shape of the needle. Here you see this needle, which over here in that area of the eye, it is rounded here, but it starts to have an edges. This is a cutting needle, and that those edges usually they like a triangle. They get tapered into this, and they become very sharp. So they are piercing and cutting parts of that. The needle can be straight or curved, which is more common. Circle of a needle, different are there, 1/4, 1/2, etc. Curve is vital in helping the surgeon to know where it is. And if you look, these are the curved needles, which they have the eye here, and they are round bodied. These are the modern those needles which they come with the suture material already pushed into that. And this is a cutting straight needle. You can see that the tapered edge here is cutting, and it has an eye also. And here, this is a round bodied needle, and these are the different shapes of the ends that are there. So these are various sutures and needles about which. So you choose a suture which is appropriate for the procedure that you are carrying out, depending upon the need of that. And also, you choose the needle straight or curved wherever it is required. For example, when you are closing abdomen, and if there is a reasonable thickness of the abdominal wall, here you use only straight needles. But straight needles, when you are passing through the subcutaneous tissue, do not allow you to include as much thickness of the subcutaneous tissue as is required. So there is a bit of compromise, and that does leave down below an area which is kind of what do you call that? A gap. So there is a gap, and you do not close the dead space completely. But if you were doing it with a round body needle, it will take all that tissue. So therefore, that is the reason that you use different kinds of needles in different places. But if you're going through the soft tissues, you use a round bodied needle. If you are going through tough tissues, then you use cutting needles, and straight or curved, and what size of needle you have to use, that again depends upon the kind of tissues that you are utilizing. Obviously, the needle that you use for circular, you don't use for bladder, right? So that so on and so forth. Similarly, for tubal ligation, you use different kinds. Now we come to the actual procedure of opening and closing of the abdomen. It is important that you hold the instruments in the right fashion. I do not know whether there is a scalpel handle here or not. There should be a scalpel handle. We have. Previously, it used to be called barred marker knife handle, barred marker, but now you would just say that this is the knife handle. And only day before yesterday, I was telling someone how to hold that. Was any one of you would be? No. It should be held not like a pen, not like this. Although I many times hold that, but if you reach my level, then you can hold it whatever way you do. But to start with, you have to hold it with your index finger over this. Imagine that there is the blade attached to this. So you hold it like this. And when you are going to apply or make the incision, then you don't move your wrist. Keep the wrist joints straight. So you use your own forearm. If you use this, then there is likelihood that you can go deeper and cut unnecessarily. And in a thinner patient, you can go through all the different layers and cut some vital structure or unintended cut, the intestine, bladder, etc., or whatever is lying behind. So you hold it like this in your hand with this, and so that you get greater control of that. So this is the start of that. And then, like the rest of it, all those instruments you hold with middle or better ring finger and the thumb, and then so that you have two fingers to act as fulcrum and give it that strength and push and etc. So you also practice it with different. So this is held like this, not like this. Many of you I have seen are holding it like this. If you hold it like this, the end of that is usually you can't see where the end of the instrument is. When you see wherever you are applying, so you know where you are applying. Otherwise, you have to be a little awkward to look at the point where it's being applied. So keep it like that in a supinated position, not a prone position, until and unless you have to approach an area where it is not possible to do it just with like that. So you hold it like this. And similarly, this scissors. Now this is the curved scissor, and it should be held in that fashion in direction where the incision is intended. If it is intended with an upward slant, then I'll hold it like this. If it is to go like this, then I'll hold it like that. So you can do it both ways. So cutting like this or like this.
So when you're cutting the rectus sheath, should it face upwards?
Yes, the point should be facing. If you are cutting it like this, because in fennel steel incision, it is a curved incision with concavity upwards, and you keep the scissors concavity also in conformity with the direction of the incision. But many a times you would see I sometimes do it like that, but only when ठीक, so वो उस तरीके से वो उसको उस तरीके से पकड़ोगे scissor. Needle holders. No, needle holders come straight needle holders, so you don't really have to bother about that. Previously, the needle holders used to come in a curve, and the curve used to be like this, that it would fit against the abdomen and curve like this. But now it is straight, so it doesn't really matter. But then there was that method of holding it. And many a times I used to point out to Dr. Rashid that he was holding it the wrong way. But he was doing it because he was professor, he could do that. So, but I told him that you are holding it this other way. Is there a special reason for that? So, you hold it like this. And again, you should practice it more often, because many a times I find that just holding it like this may not give you the liberty to do whatever you want or wherever you want to do. And therefore, you can just hold it like this. Sometimes I would hold it if there is greater strength needed or greater maneuverability is required. And that is particularly, I'll refer again to cerclage, where you have limited capacity to move the cervix and also limitation of the space. So you move it like you take a bite here, you take a bite here, and it is better. It gives you the strength of the whole hand instead of the fingers. If you need greater strength, you can hold it like that, and just when the needle has passed, you can then pass in your fingers and open it. So this is how you should practice it. You should practice it holding it and moving it like this with the needle in this fashion, and in all directions. Again, practice is required for that. So that's a needle holder. This is Babcock's and Alice tissue forceps. This is known as tissue forceps. And no, you don't hold intestine with this, but the rest of the tissues, most of the tissues can be held with this. It has teeth and its grip is quite firm. So this is tissue holding forceps, one of the tissue holding forceps. Alice.
सर सही नजर नहीं आ रहा
जी
सर नजर नहीं आ रहा सही से
ये थोड़ा सा
सर करीब आना पड़ेगा
ऐसे भी कर
लाइट्स ऑन कर दे
हाँ लाइट्स ऑन कर ये मैं दोबारा से नीडल की ये सिजर की बात कर रहे थे सिजर का ये है आप कर्व देख रहे हो ये कर्व आपके इंसियन की अलाइनमेंट के साथ होना चाहिए और इसको एंड द सिजर्स एक्चुअली सिजर्स शुड बी सो शार्प दैट जब आप अपनी तरफ कर रहे हो जो हम ऐसे ऐसे कर रहे होते हैं वो ऐसे करके सिजर शुड बी एबल टू कट इट लाइक दिस होल्डिंग इट इस तरह से अपनी तरफ कर सकते हैं लेकिन हमारी सिजर काटेगी नहीं उसको तो ये करके तो फिर भी ऐसे ऐसे करना पड़ता है सिजर ये you see this is the deterioration that has come in our country unfortunately. Pakistan was known to be a country where good surgical instruments, we took pride in our surgical instruments that they were and sports material from Salvor. Now we have this and you can't really cut it like that, but you could hold it like this. So the concavity of the scissor, the curved scissor, it has to be conformed with that. Similarly, I was telling about the needle holder with the facility. This is, you have to practice the movement at your wrist joint, how far you can go. You can go through 360 degrees if you want to, you can do that. And similarly, Alice's forceps, you hold it like this. Alice's tissue forceps, not like this, not prone, but supine. Or imagine करेंगे ये मैं इधर खड़ा हूँ और मैं I am a patient is on my I am standing on the right hand of the patient, the right side of the patient, and मैं वो rectus sheath को पकड़ने लगा हूँ तो यहाँ से rectus sheath को ऐसे पकड़ूँ. Artery, don't say artery, please. वो ठीक नहीं लगता. Say artery forceps. As a matter of fact, there used to be a method or सबकी training ऐसे होती थी. If the surgeon, I'm standing here and there is the assisting nurse is here, and if I just give my hand like that, that meant artery forceps. I didn't have to say that. The rest of the instruments I would name that I need that, but if I just give, and the method of giving to the surgeon that was like this, so that it comes with a thumb on the hand like this, so that the surgeon knows that the instrument is there while he is doing that, so that he can bring it up. So archie forceps, it's a very useful instrument. You think archie forceps is not only used to, you can hold tissues wherever we apply, for example, after the operation, when we hold we apply those 4 Alice's forceps to the peritoneal margin, you can hold that with archie forceps. And sometimes if a needle holder is not available, you can use it as a needle holder. So this is a multi-purpose instrument to catch hold of the bleeders, to catch hold and to stabilize the tissue, and to sometimes even use it as swab, etc., and also as a needle holder if there is that need. Now there are different types of these clamps. We now call them clamps. Previously, these used to be called Cocker's forceps. This is the Cocker's forceps, which has a teeth at the end. It's a curved Cocker forceps. It is a curve and it has teeth at the end. And if it is straight, it will be a straight Cocker's forceps, K-O-C-H-E-R, Cocker's forceps. And if it has a curve, it's the curved Cocker's forceps. Many people use that as clamp for hysterectomy. And as a matter of fact, it is good. Now imagine, particularly when you are applying it for the vascular pedicle of the uterine arteries, this is the cervix, this part, and it is applied. Now I am not going to apply it on my hand. Imagine that there is that protruded part at the hand of the cervix. So I apply it close to the body of the uterus. That's one way of avoiding injury to the ureter. That in benign hysterectomies, you remain close to the uterine body. So you remain close, and you see that this curve is conforming to the shape of the uterine lateral surface. And you apply this over the cervix, over the cervical area or the lower part of the uterus, and then let it slip along that, so that it brings along some of those fibers of parametrial tissue. Along with that, these teeth would bring that, and then you hold that vascular pedicle. So it will give you a good grasp of the vascular pedicle, particularly if you if you apply the tip of this clamp at and let it not hold it too tightly to hold the cervical tissue, but let it slip over that and hold that softer tissue of parametrium, which is enclosing the vascular pedicle of uterine artery and uterine veins. So this is how it should be applied, and this is a good instrument. But if it's a matter of individual and personal preference, whether you use one with the teeth or you use the simple one, which is without teeth, which is simple. And this is Cocker's with teeth, and this is without. So this is it. And then remember, these are called the dissecting forceps. Dissecting forceps, the toothed forceps and the plain forceps. So dissecting forceps, toothed forceps is used outside. And inside the peritoneum, you use always the plain forceps, until and unless there is a special occasion that you demand. So if you ask for, if the abdomen is open and you ask for dissecting forceps, the well-trained nurse would give you only plain forceps, not tooth forceps. If you have to use tooth forceps, then you specifically ask for tooth dissecting forceps from the nurse. So this is the difference. You would have observed when I am stitching the episiotomy, while I am stitching the skin area, I use tooth forceps, but at the end, close to the foreskin, because there the tissue becomes more delicate. Then I, instead of the tooth forceps, there I use the plain forceps, because tooth forceps is likely to cut through that and make unnecessary that. So this is Lane's forceps. This is, you know that it is rather a rough instrument. So you utilize it only to hold those big masses, etc., like a large uterus. You want to stabilize it, so it will give you good grip, and it's sometimes also used for myomectomy, small fibroids. So you just hold it and rotate and sponge forceps also. It's a multi-purpose instrument. It is used for sponging the area. It is used as to hold the tissue sometimes, to hold as a clamp, like in hysterectomies for placenta acrita. Many times we hold the uterine and even the ovarian vessels, with that you apply that. So you can apply that as a clamp. And sometimes if your clamp at the time of clamping the cord falls down or is not there, so you have multiple uses of that. And also it is used at the time of DMC for exploring the uterus and to bring out the products of conception. And you use the appropriate size for the dilatation of the cervix according to that. And then there are retractors. Doyne's retractor is the one we most commonly use for cesarean sections, because it retracts the lower part and give a good view of the lower segment of the uterus. So this is a very useful instrument, Doyne's retractor. And it is designed to be held like this. So there is this handle, and then there for further grip you can have this with the. And this is Morse is retractor, and there are different sizes depending upon where it is required. Sometimes if there is a restricted space, then instead of Doyne's retractor, you use this. And then these are lateral wall retractors. They come again in different sizes. And then Lever's retractor to retract back the padded and intestines and to keep the structures away. और वो जो polycystic में surgeons वो इस्तेमाल करते हैं, वो भी इस तरह से retract करने के लिए to provide. The objective or the aim of using retractors is to gain access and proper exposure. So the incision that you made should be adequate. We talked about that, the size of the incision to give good exposure. And similarly, after you've gone in, then you need to apply those retractors which are less traumatic, which are appropriate for the kind of surgery that you are doing, which will provide you the adequate exposure which is required for safe surgery. So those retractors or those means will be utilized to do that. And the way you move your hands and you move your fingers at the time of surgery should show that you go methodically in, you are not rough, you are not pulling, pushing, tearing tissues. So that all your moves should be purposeful. You shouldn't really be moving your hands to and fro just like that, but every move ought to be purposeful, that with that you are doing this. You have given that incision, catch hold of the bleeders, and these days there is a lot to be said about those blunt dissection approaches, in which you only make deeper incision in the middle and you stretch that. This is becoming more common these days. You stretch that so the vascular and neurological bundles or structures, they are not cut, they are pushed along the side. And when you do that, and some of the blood vessels, small blood vessels, which will come in way and which will get stretched and even torn off, they'll not bleed that much as they will when you make a clean incision. But that's a matter of individual approach. So if you're doing that, first you make cut in the skin and the subcutaneous tissue with the scalpel. You go up to the, we are talking of Fenner steel incision, which is most commonly carried out. And then you reach the rectus sheath. You make small incisions on each side of linea alba of the rectus sheath. And then you extend those with the scissors, its concavity in alignment with the incision, or you then stretch that. There are two methods of doing that. And then you hold that with the Ellis's forceps, ये सारा करना आप करते हो और आप देखते हो उस तरीके से। और फिर पेरिटोनियम इज कट इन from up downwards in a vertical manner. If it's a midline incision, so then you make an incision in the skin, subcutaneous tissue, and the rectus sheath, rectus sheath, because here it is only rectus sheath, it is not anterior or posterior in the abdomen above, it is posterior rectus sheath also. So you make an incision in that, and then you separate off. वो उस तरह से हो जाता है। और पेरिटोनियम को जब आप करो, पेरिटोनियम जो खोलनी है, that should be open. Now you know it a lot. It should be open as high as your incision will allow to avoid damage to the bladder. And particularly if it's a repeat surgery, then you have to be more careful about the structures which may be attached beneath that. Any other instruments? So you've done all right. What it would have been better if we had some suture material, but it's okay. So we have covered it. Any questions, please? आपके जहन में कोई क्वेश्चन आपने पूछना हो? अब मैं आप लोगों को एक तो ये कहूंगा कि आप इस सारे इंस्ट्रूमेंट्स को अच्छी तरह से पकड़ने की प्रैक्टिस करो बार बार। दूसरा आपको ये करूंगा, वो आप करो, वो लो ये जो फोम की थिन लेयर्स वाली होती है ना शीट, एक वो मंगवा दो, राइट? वो मेरे से पैसे ले लेना। हाँ नहीं मैं आपको वो ले लेना, वो आप ग्रे कलर की या व्हाइट कलर की वो मुख्तलिफ 2-3 चीजें वो शीट्स मंगवा दो। व्हाट वी विल डू दैट, उसमें इंसिजन देके देन यू प्रैक्टिस स्टिचिंग दैट। उसमें आपको पता चलेगा कि आपने नीडल होल्डर कैसे पकड़ना है, किस तरह से, एंड देन वेरियस काइंड्स ऑफ स्टिचेस। एक सिंपल सिंगल स्टिच है, एक है कंटिन्यूअस स्टिच है, एक है मैट्रेस सूचर है, वो उसको किस तरह से लगाना है, कंटिन्यूअस मैट्रेस कैसे लगाना है, सबक्यूटिकुलर तो आप लगाते ही हो, लेकिन उनकी पूरी वो जो चीज है उसको उस तरीके से देखना, तो उसको प्रैक्टिस करना। और फिर हमारे पास यहाँ वर्कशॉप में वो होगा, जो सर्जिकल स्किल्स की वर्कशॉप होती है उसमें होता है, वो उन्होंने एक कप बनाया होता है और कप के अंदर वो प्लास्टिक का कप है, उसके बॉटम पे वो एक चीज है जिसको आपने स्टिच लगाना है। So how you do that? So you learn these knots with your hands and fingers and also with instruments. ये जब deep down आपने करना है ना limited area, तो वहां से आपने कैसे करना है, so ये चीजें आपने प्रैक्टिस करनी है ताकि आप जब जाओ यहाँ से तो ये नॉट वगैरह वाला सिलसिला जो है आपका वो बिल्कुल ठीक होना चाहिए। ठीक है, सो ये करके हम उसको किसी और टाइम पे भी हम इसको इस तरह से करते हैं। ठीक है, और कोई चीज आपको जो ऐसी हो हमने जो आप देखते हो हमने इसमें इंक्लूड नहीं की वो बता दो तो भी शामिल कर दो।
क्लैम्प्स जिस तरह से डिसाइड कब करते हैं कि कौन से साइज के क्लैम्प्स लगते हैं,
कौन से?
साइजेस ऑफ द क्लैम्प्स, जिस तरह
साइजेस ऑफ द
क्लैम्प्स
Clamp?
हम करते हैं
वो नहीं वो जनरली वो जो है एक स्टैंडर्ड साइज जो है वो आ जाता है।
डिफरेंट साइजेस
नहीं वो है वो कुछ थोड़े से लंबे हैं, कुछ टेपर्ड हैं। ये दिस मेक्स मी अ लिटिल अनकंफर्टेबल, जो ज्यादा लंबा होता है जरा डेलिकेट होता है, बिकॉज़ देयर इज ऑलवेज fear of it's slipping. When it slips, actually it doesn't slip, the tissue slips through it, and if tissue slips it retracts back, and the important thing is that there would be some blood vessel within that which will retract more than the thicker tissue, तो वो उसको फिर ढूंढना मुश्किल हो जाता है। जैसे वो परसों की हिस्टेरेक्टमी कौन था उसमें, आप में से नहीं कोई था?
मैं देखती
तुम देख रहे थे उसके, she had previous 4 cesarean section और उसके adherents थे राइट साइड पे ऊपर तक राउंड लिगामेंट तक। When I opened the peritoneum and tried to separate the round ligament, तो वो उसमें से there was a breather which retracted, which went back, और फिर हमें hysterectomy के बाद उसको जरा ढूंढना पड़ा, उसको उधर लगाना पड़ा। That area actually, or the area of the uterine vessels, that's quite critical in the sense that there is close relationship of the ureter, which is passing 1 centimeter lateral to the cervix, and it is a little below the uterine vessels. So when you are applying that, so you can, if you are not careful, you can. So one thing is that we retract the bladder. When we retract the bladder and place a retractor, the bladder also gets retracted, and the ureters also are pushed a little bit laterally. So you have more than that 1 centimeter space for that. And therefore, it is important that you retract the bladder, but retract it again carefully. There are quite a few blood vessels on the side, and if you go too much on the lateral side, there will be opening up of unnecessary opening up of those blood vessels, which is quite a problem to catch hold of the control. Okay? Right.
Telling.
तो अगली दफा के लिए आप वो केस ले लोगे और वो सर से वो माया मेकिंग वाला है अनमैरिड लड़की वाला वो है मेरे पास परसों तो ये वो देख लेंगे चलो जी थैंक यू वेरी मच
Thank you, sir.